Mr. Chairman, first of all, thank you for holding this special hearing on quality, and it reminded me some of the discussions that we had during health reform. There were always scores of articles about costs, and it always seemed that quality got short shrift, and you said we ought to be going after that, and I think this is another indication that when people have these debates, we ought to not just consider the quality issue an afterthought, and you started talking about that a long time ago, and I appreciate it. All of you have given excellent presentations, and I'm just going to ask Dr. Castle a question or two, not just because in Oregon we claim her as ours. As you probably know, she's the first female dean at Oregon Health and Science University, but she was also one of the premier gerontologists that I remember reading articles about and using for the various issues that we were tackling at home. So, Dr. Castle, you really, I think, hit an extremely important issue that is just now beginning to get some attention, and that's chronic care. Back when you were looking at some of the first geriatric research in Oregon, and we were picking up on it in the Great Panthers, we remember that Medicare was a very different program. There was a lot less cancer, a lot fewer strokes, a lot less diabetes. It was not the kind of chronic care challenge that it presents today. And what Senator Isaacson was alluding to is that he and I and Senator Casey, a big group of senators, Democrats and Republicans, are very interested in this issue. And I was struck by your comment that among the challenges with respect to chronic care is that you think the quality measures with respect to chronic care are coming up short. And I was wondering what you could tell us about why that's the case. You mentioned challenges with respect to sharing data, and maybe the providers and the plans are not communicating. But what is the challenge so that we can build into these bipartisan discussions on chronic care your thoughts on getting at quality, which frankly, because of Chairman Baucus, we have a chance to do this morning. I mean, nobody else is really digging into it. So I think it's a perfect time to hear your thoughts on chronic care and quality.
Well, thank you, Senator Wyden, and thank you for your leadership in this. And I do remember those days with the Great Panthers, and I was a fellow in geriatrics at the VA in Oregon. And I remember that I had patients who would come in on a 3-hour bus ride trying to figure out what was going to be their chief complaint because they were only allowed one. And as soon as we opened the geriatric clinic, they loved it because they could have more than one medical problem, which was the reality for many of these very elderly veterans. Now, of course, as you point out, there's more and more people in our country because people are living longer, which is a good thing, but that are facing this issue. The quality measurement science and movement, if you want to call it that, has understandably focused initially on high prevalence, high yield conditions like diabetes, hypertension, heart disease. And so they have looked at this one disease at a time across the spectrum and have not put as much investment into composite measures or the aggregate of a patient's outcome overall. And often, sometimes these individual quality measures, as Dr. McGlynn mentioned, kind of backfire because what you might want for diabetes in somebody who doesn't have any other problems could be very different with a patient who also has Alzheimer's disease and is suffering from 2 or 3 malignancies and other kinds of issues, perhaps in a nursing home. So really, we need an investment in this area of aggregating information and having it all be patient-centered, all be around the individual patient and their function and their values. In order to do that, if that weren't challenging enough scientifically, we also need to get the data together from sectors outside of hospitals and doctor's office, the traditional area that we're looking at right now, and the long-term care and community providers, who you're so familiar with, have to be part of this picture as well. So I think that's doable, but I think it just needs to be lifted up and be made a higher priority.
I just have a few seconds. Do any of your colleagues want to add to this?
So I would just add that quality measurement follows in the wake of clinical science. And frankly, clinical science hasn't really figured out conceptually or practically how best to deal with patients with multiple morbidities. And so I think that this is something we need to do together, is to figure out how to think about that. The clinical science is pretty siloed itself. And I don't think just adding adding up the individual silos is going to get us where we need to go. And so these examples of engaging patients to set goals for themselves and then to measure how well the system is delivering against those preferences is an area I think we really need to explore for this population.
Let's do this. Chairman Baucus has been good enough to let me do this. We've got a vote on the floor. Any of you who would like to make additional contributions on the question of chronic care and quality, Dr. McClellan has also been very interested in this, for years. For any of you four, it's been a terrific panel. And again, Mr. Chairman, I really appreciate your doing this.